We will start with primary angle closure suspect. Should we do a laser peripheral iridotomy or not? Dr. Thomas George, who is a very wise man in glaucoma, will speak on the topic. He is from the Chaitanya Eye Hospital and Research Institute in Trivandrum.
Thank you, Kiran, but I'm not sure if all that is appropriate. Okay. Angle closure glaucoma, we have learned, is a very straightforward thing. Primary angle closure causes relative pupillary block. Iridectomy or iridotomy is the way to go about it to get rid of the pupillary block. And laser being easier, now the way to go is laser PI. But do we need it? Does it work? And such questions are relevant because PI doesn't work in everybody, and that we all see clinically every day, especially when it's at a PSCS or PSC stage where the disc is normal, there's no visual disability, no field problems at all. The incidence data has been with us for a very long time. There's a well-organized survey, which one of the people who actually did the survey will come in for a talk later, and that's Ebi. And 22% of PSCS did progress to PSC in 5 years. None went on to PSCG. And PSC to PSCG was 11% in those who underwent PI and 36% of those who refused a PI. That's because our Vellore protocol was once we see a Sinecure, we do a PI. So the PSCS, not everybody got a PI. Next, we go on to the Chennai glaucoma study, which was also a very old study. Incidence of primary angle closure disease is 4% in 5 years. That's from normal to even PSCS. And 87% of these closures that were named 5 years down the line were PSCS or primary angle closure suspects alone. So incidence of PSCG is low even in a primary angle closure suspect, and a PSC, and PI does not protect all, though it does seem to have some protective effect that we knew all along for years. Now more evidence has come up in the recent past, and that's the ZAP and Analyst trials, which specifically aimed at does PI protect. So ZAP is done in China, and Zhongzhang angle closure prevention trial, and they screened 11,000 people for eligibility, and 870 were considered subjects. PI was done in one eye, and the other eye was kept as a control with a 6-year follow-up, and they did not do an indentation gonioscopy. That is a drawback, and PSCS is counted in, and 2-quadrant trap not visible was what they used as inclusion. Excluded those on whom a prone provocative test or dilatation raised IOP, and over 30 mm edge also excluded. So obvious closures were taken out. And with OCT, about a quarter of them had residual PSCS even after the PI, and PAC, primary angle closure, that Sinecure occurred in 4.19 per 1,000 eye years as they reported the study, as opposed to 7.97 in 1,000 eye years in the untreated eyes. So primary outcome came in 19, and the other one was 36 over a 72-month follow-up period. So it does suggest a 50% risk reduction. That's 4 versus approximately 8 is the incidence data they gave. And incidence of PSC in PSCS is low. PI does not protect all, but it reduces the risk by a factor of 2. So analysis was done by a group of investigators who were part of the ZAP trial to cover for the drawbacks. It is done in Singapore, and again PSCS multicentric in Singapore. They had 480 individuals over 50 years, bilateral. 2-quadrant apposition was the inclusion criteria, PI in one eye and the other eye as control. And outcome was either Sinecure or PSCG with optic neuropathy or acute closure event in the follow-up period. Most of them were Chinese even here, and women were 3/4 of the population. That's the skew factor that we need to think about. And 5% of the eyes treated with PI reach the endpoint, that is, go on to a next stage, PAC or PACG, and 9.4% develop PAC in the control group. So once again, we are looking at a 50% risk reduction with PI, but the incidence itself is very low, is again established. The hazard ratio here is 0.55. So again, we are looking at a 50% risk reduction. But if you are looking at an older participant per year, there is a hazard increasing, and a higher baseline IOP per millimeter of mercury, also the hazard ratio increases. So older patients with higher IOPs at baseline were more likely to reach the endpoint is one more thing that the analyst told us. And the number needed to prevent one event of closure or PAC was 22. You have to do 22 PIs for one person to benefit. So this is just the calculation. I'll jump that, short of time. So now we know that the risk of progression reduces to half with PI, though it is not eliminated. The absolute risk of progression without PI also is not very high. So what do we do? PAC is to PAC, the incidence is low, so do a PI or watch. Both have a rationale in our clinical decision making. And PI does not prevent closure in all. So a PI does not absolve us of the need to tell the patient he needs follow-up even after a PI. So essentially, it's a case-by-case decision even now. If the patient is unable to come for follow-up, we'll reduce the risk by half by doing a PI. If the patient needs frequent dilatations, the risk is considered higher, we do a PI. If patients, from the analyst, we know if the patient's got a higher IOP or a higher age bracket, we would do a PI more often than not. But you are justified in watching the patient and telling them they need a follow-up as well as doing a PI. So the choice is still back with you. I have not told you anything specific. Thank you.